Securing a yes from a prescribing physician feels like the finish line in healthcare sales. But clinical intent does not guarantee treatment execution. This diagram tracks total prescriptions against actual patient fulfillment. Look at the highlighted portion. 27% go completely unfilled due to access barriers. Filtered for Medicaid populations, that failure rate expands to 34%, reflecting even more severe constraints. Historically, field teams relied on a straightforward sequence. A representative influences a prescriber, the prescriber writes a script, and the patient receives care. Today, that sequence is severed. Once the prescription leaves the doctor's hands, it immediately hits a wall of cost barriers, payer coverage restrictions, and ultimately patient abandonment. Getting a signature is no longer the primary hurdle. The actual execution of care is trapped behind systemic, post-prescription barriers that field teams have to understand and navigate. Healthcare accounts are operating under immense structural pressure. 92 million Americans live in primary care shortage areas, leaving providers with massive patient volumes, tighter staffing, and punishing financial constraints. To handle outreach at scale, commercial models relied on standard customer archetypes and uniform messaging. It was a reliable way to ensure field teams operated consistently across broad territories. But standardization fails in a constrained environment. Providers already have immediate access to clinical evidence and treatment guidelines online, and care delivery itself has fragmented across outpatient and specialty settings. Overcoming these barriers requires a completely different approach. Customer-first selling is a structured organizational capability. It shifts a representative's focus away from driving raw prescriber volume, pointing them instead toward total account alignment. In a highly selective environment, high-volume reach and frequency become secondary to extreme relevance. Relevance is the entry point that determines whether an engagement happens at all. Many commercial organizations assume they are providing actionable insight simply by handing their field teams a CRM dashboard full of data. Those systems and prescribing models only describe historical patterns from a distance. They capture what happened last quarter, but they offer zero explanation for how a decision is actually made inside a specific clinic. Active influence begins when representatives stop observing passive data and start building a working, dynamic model of an individual account. This model needs to map physical realities. Representatives have to track exactly how patients move through the system, where care coordination breaks down, and which specific operational bottlenecks slow down treatment. You cannot pull those answers from a dataset. They emerge through structured investigation, asking deliberate questions, testing assumptions on the ground, and paying attention to informal signals. Context dictates meaning. A large hospital system focused on throughput and bed capacity behaves entirely differently than an independent practice trying to manage patient volume and reimbursement protocols. The teams that outperform their peers don't rely on raw data alone. They are explicitly trained to interpret, validate, and act on the exact nuances that algorithms completely miss. Having a clear picture of the account is only the first step. To execute, that information has to reveal exactly where influence lives and how it travels. Focusing solely on the prescribing physician is an incomplete view of modern healthcare. The doctor is no longer a solitary actor. Notice how this network expands. Decisions are actually controlled by a complex matrix of stakeholders, and their individual priorities rarely align. Clinical stakeholders sit here, focused entirely on evaluating treatment appropriateness based on evidence and patient outcomes. Meanwhile, their operational partners are looking through a different lens, managing daily workflow, staffing capacity, and overall facility throughput. Then you have the economic and administrative roles. They control access, dictate affordability, and set strict rules on whether external partners can engage the practice at all. If a field team fails to engage even one of these nodes, the clinical intent generated by the prescriber hits a wall, and patient progress stops entirely. Matching the complexity of this external network requires tight internal coordination. Account managers, reimbursement specialists, and clinical educators must move together, executing a single, unified strategy. Insight and access create an opportunity, but message curation determines whether that opportunity actually translates into action. Delivering the exact same corporate value proposition to every role we just mapped is a critical error. It strips the message of all relevance and guarantees it will be ignored. A single insight must refract through different lenses, tailored perfectly to the specific priority of each unique stakeholder. Legacy field models fail here because they treat sales calls as isolated, standalone events. They push for a close in a vacuum. Successful engagement is a long-term arc. Belief develops progressively as representatives introduce new information and carefully connect it back to the account's existing, long-standing priorities. Executing that progression requires high empathy and active listening. Representatives have to drop their assumptions and adjust their strategy in real time the moment a customer pushes back. When executed precisely, message curation is the mechanism that turns static account insight into measurable forward movement for the patient. This level of customer-first selling does not emerge spontaneously just because marketing rolled out a new slide deck. The primary barrier to adopting this capability sits directly at the executive level: performance models that prioritize sheer activity volume over strategic penetration. If performance is measured by reach and frequency, field teams optimize for those numbers, resulting in scattered, superficial interactions that fail to move the needle. Look at this comparative matrix. The customer-first model values the ability to diagnose account dynamics and map influence. Expanding focus on the right incentivizes what actually matters: depth of account understanding, quality of stakeholder engagement, and progress against strategic objectives. Because measurement dictates behavior, commercial leaders must align field incentives with these specific account-level outcomes to drive results in complex environments. This also requires a shift in learning and development. Rapid information transfer and passive content exposure will not build these skills. True capability is built through application. Representatives need dedicated time to work through highly realistic, constrained account scenarios before they face them in the field. And the ultimate drivers of that behavior change are the field managers. Managers have to transition away from simply tracking call logs. They need to coach the cognitive process, probing how a representative interprets complex dynamics and why they prioritize one stakeholder over another. Sustainable execution happens only when capability training, managerial coaching, and incentive metrics are systemically locked together. Customer-first selling operates as a rigorous organizational capability, requiring specific internal structures to sustain. Organizations that cling to standardized, volume-driven approaches will face diminishing returns as account access becomes even more restricted. But the teams that master this architecture earn compounding rewards. They secure unparalleled access, they exert effective influence, and they elevate themselves to the status of indispensable operational partners.